Welcome back to the deep dive. So, I want you to picture the most complex, highly organized city you can imagine.
Okay.
A place where everything is manufactured, managed, maintained with just microscopic precision.
Right.
That city is you. And today, we're diving into its ultimate infrastructure, cellular regulation. This is the master plan that dictates, well, not just survival, but the very quality of life itself.
And we've been deep in the source material on this. We've been analyzing this incredible biological control system, specifically looking at what happens when it all breaks down.
Right.
We're looking at the intense treatment protocols for major diseases like leukemia and sickle cell disease.
So our mission today is a true deep dive into the body's fundamental units. We want to understand the sheer scale of coordination that's required just to stay healthy.
And then dissect what happens when that system fails.
Exactly. To really get into the weeds on the rigorous, multifaceted treatment strategies that are necessary when the body's master manager, just goes off the rails.
And it really starts with appreciating the scale, doesn't it?
Yeah.
It's not enough to just say the cell is the basic unit of life.
No, not at all.
We're talking about trillions of these units.
Yeah.
Trillions. Each one with a specialized job, and they all have to coordinate perfectly.
Just for basic functions, right? Like breathing, thinking.
Breathing, thinking, fighting off a cold, all of it.
It's just a staggering number. And that brings up the big question. Who's the manager here? How do you maintain quality control over trillions of workers at the same time?
That is the absolute core of cellular regulation. It's this constant active management system. Think of it like a highly automated factory floor manager.
Okay.
Its whole job is to precisely regulate the reproduction, the proliferation, and the growth of every single cell.
And if a cell is defective?
It needs to flag it and eliminate it. If the body needs more oxygen carriers, boom, it ramps up production. It's inventory management, quality control, production scheduling, all running 24/7.
And if we trace this all the way back to the beginning, to the origin point, we're always starting with stem cells.
Always. They're the blank slates.
The blueprint holder.
Exactly. The ultimate progenitors. They can become almost anything the body needs. And in the context of what we're talking about today, the blood and immune system, they differentiate into three crucial products.
Which are?
The essential trio. You've got your white blood cells, your WBCs, which are your immune defense.
Right.
Then you have red blood cells, RBCs, for all your oxygen transport, and platelets, which are your critical clotting agents. When regulation is perfect, you have just the right amount of each. It's a beautifully balanced, self-healing system.
So what happens when the factory manager goes rogue? This is where it gets truly intense. We have to look at pathology and specifically leukemia.
Yeah.
It's just a devastating example of cellular regulation failing and failing spectacularly. Instead of that balanced assembly line, you get an unregulated explosion.
It's an unchecked proliferation, usually of abnormal white blood cells. The whole system just gets overwhelmed by these defective, rapidly dividing cells.
And they crowd out everything else.
Completely. They crowd out the space needed for healthy red blood cells and platelets, which is what leads to those dramatic clinical manifestations you see.
And with a total systemic collapse like that, you can't just, offer a simple fix. The treatment has to be multimodal. It has to be incredibly intensive.
The goal is always a total systemic reset.
A reset.
Which often leads to transplantation.
Yeah.
And that is arguably the most extreme form of reset you can get. We're talking bone marrow transplants, stem cell transplants.
Okay, let's unpack that because the sources make a critical distinction between allogeneic and autologous transplant.
Yes, and it's a huge distinction for you to grasp.
So allogeneic is from a donor, someone else. Autologous means using the patient's own cells that were harvested and cleaned. My first question is, why would a doctor ever choose a donor's cells if using your own guarantees no rejection?
And that's the absolute crux of the clinical challenge. You're right, autologous transplants mean zero risk of rejection, no graft versus host disease.
Sounds like the obvious choice.
But, and it's a big but, they're only viable if the patient's harvested cells were completely free of the malignancy. And that's often a massive challenge.
I see. So you might be reintroducing the cancer.
You might be. Whereas an allogeneic transplant from a healthy donor offers a truly clean slate. And crucially, you get something called a graft versus leukemia effect.
Meaning the new immune system hunts the cancer?
The donor's new immune system actively hunts down any remaining cancer cells. But that advantage comes with the serious, potentially life-threatening risk of graft versus host disease, where the new cells attack the recipient's body.
Wow. That is a tightrope to walk. And beyond the transplant, the pharmacologic warfare is also highly structured. Chemotherapy isn't just one thing.
That's right, not at all. It's regimented into two critical phases. The first is the induction phase. If you want a quick analogy, this is throwing the kitchen sink at the problem. It is the initial, extremely aggressive attempt to achieve complete remission by destroying as many cancer cells as possible, as quickly as possible.
That sounds brutal.
It is. It's incredibly taxing, often requires hospitalization.
And what happens after that initial assault?
Then you move into post-remission therapy. The goal here is just prevention.
A mop-up job.
A strategic mop-up, exactly. Induction may have gotten you to remission, where the cancer is undetectable, but we know there are always microscopic remnants hiding.
So this is to hunt down the stragglers.
Exactly. Post-remission or consolidation uses chemo or sometimes high-dose radiation therapy to make sure those invisible threats don't come back. And now we're also seeing more advanced things, like biological therapy, which uses the immune system itself.
It really sounds like a full-scale war inside the body. But at the same time, they're not just fighting the disease, they're fighting the consequences of the disease.
Precisely. Because the rogue cells have crowded out the healthy ones, the patient is dealing with three major crises, constantly.
What are they?
They're managing severe anemia, which is that profound lack of healthy red blood cells. It causes this deep exhaustion.
Okay.
They're intensely mitigating infection risk because their white blood cells are flawed, and they have to control bleeding because of the platelet shortages. Managing these symptoms is often just as critical as the chemo itself.
Okay, let's pivot now completely. If leukemia is the manager going rogue, what happens when the factory just produces bad parts?
A manufacturing flaw.
Right. We're shifting our focus to a different kind of problem, sickle cell disease. The regulatory system is working, but the cells themselves are just malformed.
It's a structural flaw right at the core.
Oh.
In sickle cell, the hemoglobin, the protein inside the red blood cell, is defective.
And that causes the shape change.
It causes the normally plump, flexible red blood cells to deform into this rigid sickle shape when they're deoxygenated. And those sickle cells get stuck. They block tiny blood vessels, and that causes immense pain and organ damage.
So when the cell itself is structurally flawed like that, does the whole treatment philosophy have to shift? The source material shows a similarly holistic approach, but it seems geared more toward chronic compensation, maybe, not just acute eradication.
That's a great way to put it. You still see that commitment to a cure, with bone marrow or stem cell transplants being mentioned. They're still the only potential cure because they replace the flawed blueprint.
But that's not an option for everyone.
Not at all. For the vast majority of patients who are managing the disease day to day, the focus is all on mitigating the consequences of that flawed structure.
And mitigation means constant active support.
It does. So alongside regular pharmacologic therapy and frequent life-sustaining blood transfusions to replace the bad cells, the daily support is intense.
What does that look like?
Well, during a pain crisis, a vaso-occlusive episode, the immediate interventions were all about getting things moving again.
Unblocking the pipes, so to speak.
Pretty much. That means aggressive support for oxygen and circulation, immediate hydration to literally thin the blood, and intense pain management. And, just like with leukemia, constant vigilance to prevent and manage infection.
And why infections specifically?
Because the spleen, which is critical for immunity, can get really damaged by repeated sickling episodes.
You know, a great sticky detail for you listening is how the...
They only last about 20 days, instead of the normal 120.
Wow.
So the bone marrow is in this state of constant, desperate, high output production. Folic acid is essential for making new DNA, for cell production. And you need the high calories and protein to fuel that nonstop emergency cellular factory.
It just illustrates the massive systemic drain from a single tiny manufacturing flaw.
So to sort of synthesize all the complexity we've been exploring, cellular regulation really dictates survival. And the ways it can fail are so varied, from a rogue manager in leukemia to a faulty part in sickle cell.
Right.
And in either case, the treatments have to be just as varied and intensive. They range from precise pharmaceutical intervention, like that highly structured induction phase of chemo,
to something as fundamental as just maintaining a very specific nutritional profile, like the high calorie and folic acid intake. And what we really hope you take away from this is that understanding regulation is the key to understanding health. These specific details we've focused on, like, the necessity of a clean slate in an allogeneic transplant despite the risks, or that kitchen sink urgency of the chemo induction phase, or those hyper-specific nutritional demands, These are the nuggets that turn generalized knowledge about a disease into genuine insight about the body's magnificent but also very fragile internal architecture.
And that raises a really important question for you to consider based on what we've just reviewed. We see medicine using these profound corrective measures, like transplants that try to completely fix the core cellular process.
Yeah.
And then purely supportive measures, like aggressive symptom management for pain or anemia or nutrition. Looking at the immense challenge of these diseases, is modern medicine today more successful in actually fixing the basic unit, the cell? Or is it more successful in simply managing the immense, cascading consequences of its malfunction? Think about that precise balance between permanent correction and endless support.